Thank you. Thank you very much. And also, I would like to start by thanking the organizers for having me here and giving me the opportunity to present our study at this meeting. So, I would like to present to you another model comparison study on treatment as prevention for HIV in South Africa, but I promise it will be different from what Jeff just presented. We focused more on the prospect of elimination. I'd like to start by acknowledging all my co-authors, which you see listed here, and our funders from the HIV Modeling Consortium. So as you probably all know, universal test and treat is an intervention that has been suggested to drive the HIV epidemic in South Africa into an elimination phase, defined as an incidence below 1 new infection per 1,000 person years in South Africa by Ruben Greenwich and colleagues in their landmark paper in The Lancet a few years ago. And in response, many other modeling groups have tried to reproduce this positive results, yet failed to do so. And as Jeff just told us, there is a wide range of different models now available that look at the impact of ART on HIV epidemics, yet they all differ in what kind of impact they predict, and it's hard to disentangle which factors actually cause these differences, because they are so profoundly different in a lot of aspects, such as structure, parameterization, and other assumptions. So we used our STD-SIM model to examine the impact of different model structures and parameterizations on the predicted impact of universal test and treat in South Africa. So to this end, we developed 9 different mathematical models of the South African HIV epidemic in a stepwise approach of increasing complexity by adding a different component to the model every time, at every new step. So we start off by model A, which is actually a representation of the deterministic model by Ruben Greenwich and colleagues from their Lancet paper. And then we expand this model by adding all sorts of components, and then finally arrive at model D, which is the full STD-SIM model. And at each step we investigate the impact of a universal test and treat intervention, which means that the population is screened annually at 90% coverage, and all HIV-infected patients are put on ART immediately, starting in 2012. As much as I would like, I'm not going to go into detail into all the model structures and assumptions because there simply isn't enough time. I'd just like to go over the results with you, and I'm going to start with model A. So like I said, model A is a representation of the deterministic model by Ruben Greenwich, with the only difference that it's now simulated using an event-driven microsimulation approach. So we simulate a population aged 15 to 65, there's random sexual mixing, we have a single HIV transmission probability, and we use a prevalence density function to arrive at the steady state HIV prevalence that is observed in South Africa. We assume the intervention to reduce infectiousness by 99.4%, which is 99% effectiveness due to ART, and then on top of that, 40% reduction due to other prevention interventions. And we parameterize the model to UNH reported HIV prevalence for South Africa. So here we see the predictions for model A. The stars here are the UNH reported HIV prevalence data. The solid line is the predicted impact of universal test and treat, and the dashed line shows you the no UTT counterfactual. And as you can see, after introduction of the intervention in 2012, there is a large sudden quick drop in HIV incidence to below the elimination threshold of 0.1% incidence after just 6 or 7 years. And in terms of overall impact, this is also quite substantial. So we looked at the number of life years saved per administered ART treatment year, and we see that by 2050 this model predicts that there will be about 6 life years saved per every ART treatment year administered. So there's a huge prevention effect on top of the survival effect. So to this model we then added an age-structured population and heterogeneity in transmission by HIV disease stage. So we add demographic projections using United Nations data on background mortality and fertility rates, and we add different stages of the HIV infection, including acute infection, symptomatic infection, AIDS, in which transmission rates differ. And then we arrive at the following predictions, where we again see that there is a large drop in incidence after introduction of the intervention, yet not as far as predicted by Model A, but the rapid decline stops earlier. However, the model does predict that incidence will decline over the coming years and eventually reach the so-called elimination phase at around 2045. If we look at the overall impact in terms of life years saved per ART treatment year, we see that this is now twice as low as what was predicted in Model A. So there's 3 life years saved instead of 6 per ART treatment year. Then in the next step, we added heterogeneity in sexual behavior and sexual networks. So we model relationships and commercial sex work. We also add explicit modeling of HIV prevention interventions to explain the steady state in HIV prevalence. So we add condom use, we add circumcision, we add STI cofactors, we add treatment for STIs. And we also changed our assumptions regarding ART effectiveness, so we no longer assume 99.4% reduction, but just a conservative 90% reduction in infectiousness. And we further assumed the survival benefits to be twice as high, which gave a very good fit to observational data from a rural area in South Africa. And here we see the predictions for Model C. Again, you see a large drop in HIV incidence after the introduction of the intervention. But if you look at the counterfactual scenario, here you also see reduction in incidence without the universal test and treat intervention. And this is because now we explicitly model the background prevention interventions that were left out in the other models. And because the incidence in the counterfactual already declines, the decline in incidence in the intervention scenario makes that elimination phase is actually achieved earlier compared to Model B. However, because of the declining incidence in the counterfactual, we see that the impact of the intervention is again lower, that we now have about 2 life years saved per ART treatment year. So then we move on to Model D, our final main model in the analyses, where we added CD4 cell count progression over during HIV disease progression and the current ART scale-up in South Africa. I just want to briefly touch upon how we model the ART rollout. So there's 2 submodels within our model. That one is determines the health-seeking behavior of individuals, and this is increased as the HIV disease progresses, so people with advanced disease are more likely to seek care. And we have a health system capacity to meet the demand from this health-seeking behavior, and this is used to scale up access to ART. And we fitted this to WHO reported data on ART coverage, and this is what you see here. So we have on the left side the proportional coverage of the total number of patients eligible, and here we have the total number of patients in both. So the gray bars are WHO data, and the black bars are model predictions, and the model can accurately replicate the data. So if we go to the projections of this model, we see a picture that is quite different from the other 3 models. What we see here is that incidence in the pre-intervention period, so let's say 2004 to 2012, is already declining rapidly. And this is because the ART is rolled out at 350 cells, well, first at 200 and then at 350 cells microliter in South Africa. And as you see, the counterfactual scenario of continued scale-up towards universal access already has such a substantial impact on incidence that here the actual elimination phase is achieved at around 2045. Yet the UTT intervention still has a substantial impact on the epidemic, driving the HIV epidemic into the elimination phase at around 2035. In terms of overall impact, it's again a bit lower compared to the other 3 models. Since this model allows for a realistic comparison of the UTT intervention with what is currently happening in South Africa, we also did a cost-effectiveness analysis of the UTT intervention compared to continued scale-up of ART at 350 cells a microliter. So here you see the cumulative net costs of the UTT intervention. I don't think I have time to go into details about our costing assumptions. And here we see the number of life years saved due to the UTT intervention compared to continued scale-up of ART at 350 cells a microliter. And combining these two, we get an incremental cost-effectiveness ratio of $170 per life year saved, which is highly cost-effective. So in summary, we find that all our main models actually predict elimination of HIV, yet this, predict the reaching of the elimination phase. Actual elimination we didn't look at, which is 0 incidence, 0 prevalence, yet substantially later than previously predicted. And we found that several components within our model were very important in explaining this difference in model prediction. So taking into account sexual networks, background prevention interventions, ART scale-up, and heterogeneity in HIV transmission seem to be very important to be taken into account when modeling test and treat interventions. And also we found that the predicted impact of UTT declines as model complexity increases. Furthermore, we found that the current ART treatment rollout in South Africa may already have such a substantial impact on the HIV epidemic that it could drive the epidemic into the elimination phase if current scale-up is maintained and universal access is achieved. However, the universal test and treat is still highly cost-effective at $170 per life year saved. We performed extensive sensitivity analysis, but my time is up, I think. So, thank you.
Thank you.